So I am pleased to introduce Dr. Anjali Sadhwani. Most of you know her as well, and she is going to talk to us about understanding the critical clinical outcome assessments, or COAs, used in clinical trials. Anjali?
Good afternoon. I'm thrilled to be here today. Thank you so much for having me. I'm Anjali. I have been in the Angelman syndrome space for the last 13 years, and I've seen the therapeutic landscape change over time. I've seen the minocycline trial, the levodopa trial. I feel very honored to be part of this exciting time right now, where there's clinical trials happening, and there's so many more to come. What I want to do is talk about the clinical outcome measures that are used in these clinical trials. Jennifer, thank you for setting the stage for me. Okay. These are my disclosures. I've received funding from the NIH, ASF, FAST, and ABOM, including Roche Pharmaceuticals as well. Okay. Let's talk about outcome measures used in trials. There's several types of outcome measures used in trials. The first one is performance-based outcome measures. This is when we tell someone to do something. Can you put the pegs in the pegboard? Can you walk? Can you go up and down the stairs? They're patient-reported outcome measures where we ask the individual how you're feeling. Are you sad? Are you anxious? This is not applicable to kids with Angelman syndrome because they're predominantly nonverbal. They're observer-reported outcome measures where we ask you as parents, how is your child doing? How does he eat? What's he like in terms of his feeding and utensils? Where is he in terms of toilet training? And they're clinician-reported outcome measures where clinicians rate your child's gait, their gross motor skills. And it is important for clinical trials that the FDA approves these measures. Okay? Outcome measures assess samples of behavior. We want to let you know that as clinicians, we know that these outcome measures do not represent your whole child. We know that your child is more than that. They don't necessarily directly reveal traits or potential. They cannot completely predict a person's success, but they must have adequate reliability, means they're consistent, and validity, which means they're accurate. We also know that results can be affected by a lot of factors. Your child didn't sleep well. He had a seizure the previous night. His cooperation, his behavior, all affected. These results are just estimates of predicted functioning, and we have to interpret these results in the context. There are certain characteristics that are required of outcome measures. It's important that these outcome measures have validity, that they accurately assess what they're saying they assess. They're reliable, that they capture data in a consistent way, consistent way across setting, across raters. They're psychometrically sound, that the items hang together in space, and items assess a range of difficulty and can discriminate between patients. And they're sensitive to change. They can detect change over time and the change that is meaningful. What domains of development are assessed in a clinical trial? I'm a psychologist, so I'm only going to be talking about development, right? So these are the domains that are assessed. We look at cognitive skills. We look at your child's learning. We're looking at problem-solving skills. We're looking at adaptive functioning, which are day-to-day skills to take care of themselves, to socialize. We're looking at receptive language, which is what your child understands. We're looking at expressive communication, what he communicates. And when we look at communication, we're not only looking at the vocalizations, but any way your child communicates, signs, gestures, AC device. We're looking at fine motor development. How does your child manipulate objects using his hands? Gross motor development. How does your child navigate his environment? We know these are the domains that we want to assess. We know that these domains, most of them, are clinically meaningful to parents, as showed by the disease concept study. So what are the appropriate tests to capture these domains? When we look to assess cognitive development, there are challenges in using traditional IQ tests. Most IQ tests require a minimum set of basic skills to be valid, which all of our kids don't have. Some may have it, but all don't have it. You must be able to see and hear materials. You must be able to follow 1- and 2-part directions. You need to match which one goes with which. You need to have an isolated point. You need to demonstrate one-to-one correspondence. You need to be motorically initiate a two-step action. Can you make the blocks to put it together this way? Most IQ tests require language. There are exceptions to this. They are nonverbal IQ tests, but the motor demands of this test are very, very high. If an examinee is unable to complete 1 or 2 items per test, then the test cannot be considered appropriate for that individual. And given the level of functioning of our kids, most individuals with AS score on the floor of the test. This makes measuring performance and change challenging. There are also challenges in the interpretation of test scores that we have. You probably have seen different scores in different times. I just want to explain what those scores mean. You probably get a raw score on a test. You get a raw score of 51, 57. Those individual raw scores are hard to interpret. Those raw scores it's hard to compare change on raw scores depending on where it occurs on the scale. A change of raw score of 1 or 2 on the lower end of the scale is very different than a change of 1 or 2 on the higher end of the scale. We've also heard of standard scores. What standard scores do is it takes the raw score and converts it based on the chronological age of the child and gives you a standard score. It compares your child's performance to other children their age. So we already know, compared to other children, the standard performance score is lower. And over time, that gap gets higher and higher. So you tend to have a lot of floor effects, which are problematic. The age equivalent scores tell us what the level of skill at what age we would expect a typically developing child to have it. And it's really hard to compare a 14-month level to a 20-month level. So they lack the psychometric properties for comparison. So what are the options left? So one of the options that we have, and the best right now we have, is the Bayley Scales of Infant Development to assess development. First of all, I want to tell you, we know it's not perfect. We know it has a lot of flaws. I've had a little bit of time thinking about these measures in my space here, and I truly want to say this is the best we have right now. And what I want to say is what we have, what data are we getting, and how do we make it better? So what is the Bayley Scales? It's an in-person assessment done by a trained psychologist. It assesses development in 5 domains: cognition, receptive communication, expressive communication, fine and gross motor skills. So you know these domains are the same ones which parents found meaningful. Items reflect problem solving, visual spatial skills, approach to novel tasks, and learning. It's a well-validated measure of developmental progression, and it is sensitive to change. Even though the Bayley has been technically normed up to 42 months, it is very often used in individuals with developmental disabilities. Why should we use the Bayley? It doesn't heavily rely on verbal skills. A lot of the items are just visually demonstrated, so your child picks up what is needed to be done. It allows for modification to testing procedures. All individuals can complete some task on this measure. It has been used in many studies and clinical settings, so it provides a basis for comparison, and has been used in prior clinical trials in Angelman syndrome. Assessing scores on the Bayley to capture change. There's several scores you get at the Bayley, and I'll just talk about the different ones and what are better to capture change. The first one are standard scores. They're not generated for anyone greater than 42 months of age. Raw scores are often hard to interpret. Age equivalents, multiple raw scores compared to the same equivalent score. So if you have a 1-point change in raw score, you may still land up with the same age equivalent, and you can't notice change. The rate of change in age equivalent is not comparable. So what is a possible option? One possible option is the growth scale value. It's based on the item response theory, and it's directly derived from raw score using a conversion table provided by the publisher. It measures development on a continuum and uses an intervals level of scale. That means a 5-point GSV on the scale, anywhere on the scale, is comparable, and it has good statistical qualities to detect improvement over time. In fact, it is the best measure to assess change in developmental progression. So what have we seen? We have been able to show change using the Bayley, using the GSV scores. This is data from the natural history study. Dr. Tan just previously showed it. As you can see, the purple and blue are the deletion types, and the other colors are the non-deletion type. what you can clearly see is a demarcation that the individuals with deletion are developmentally slower than the individuals with non-deletion. We all know that. But what is really, really great about this scale, you can see that our kids are making progress over time. Yes, it's small, but they're still continuing to make progress, and we're able to show change over time. When you look at the expressive language domain, you're seeing it to be mostly flat. That's because the Bailey scale only assesses verbalization. It doesn't take into account any other way of communicating. And that's why you'll see it mostly flat. We don't expect verbalizations to change over time. And except for the UB3A, who have an increasing number of skills, they are increasing, whereas everybody else in the expressive domain are mostly flat. So what we see here is that individuals with AS, at least up to 13 years, are continuing to make gains in development. So we're able to capture change over time. So what is being done to improve the Bailey use in AS? The previous strategies, we had actually started this in 2017, where when one of the ASFs, thanks to funding from the A-bomb, we had brought together a whole group of people, clinician, expert raters from the Bailey, thanks to Terry Jo's leadership, to talk about strategies of how we could improve the Bailey. And what we did is we took all the data we had, we reviewed all the more difficult items, we talked about standardization of instructions, we've provided recommendations for support, like when can you provide elbow support for the child for the ataxia? We also realized across sites, clinicians were starting at different ages, so we provided guidance along start points. We slowly realized that we did provide this information, but we don't know how it was used, and we certainly realized it wasn't enough. Thanks to the A-bomb, we got funding, Dr. Ann Bila and I, to actually develop a neurodevelopmental testing training manual for Angelman syndrome. We received funding for this recently, and I just want to share a little bit about the work that we're going to do about this to make the Bailey a more sensitive measure. These are the steps that we're going to do. And as part of the first step, we're going to do an item review. We're going to do a video review of administration. We're going to have a discussion with stakeholders. We had an advisory board meeting 2 days ago where we got pharma on the plate, we got clinicians on the plate, we got the advocacy group on the table to just discuss what are the challenges you're seeing in this measure so that we can take it all together and then figure out how to make it better. We're also going to be interviewing with the evaluators, the people who are actually doing the administration, what challenges they see, as well as the parents. We're going to ask the parents what is their experience on the Bailey. Once we get all this information together, we're going to be meeting with a certified trainer to develop better accommodations and recommendations for improving item administration. We're going to be providing guidelines for training of new administrators, and we're also going to be developing a measure of fidelity and validity. Finally, we're going to be disseminating this final manual across different studies, clinical settings for the trial, so everybody's administering the Bailey as much as possible in the same way. And we're also going to be developing video modules for future administration. Sorry. So the Bailey covers cognition, language, and motor. The domain that is left is adaptive functioning. Adaptive functioning, as I said, are day-to-day skills for everyone to take care of themselves and get along with others. The best measure for adaptive functioning is the Vineland Behavior Scale, which is a parent-completed measure where we ask you how your child is doing. It assesses development in 10 domains: communication, motor skills, socialization, daily living skills. As you can see, 4 of those domains, communication, receptive and expressive, fine and gross motor, those domains overlap with the Bailey as well. Similar to the Bailey, we've been able to take natural history data and show that the Vineland is able to show change over time. It clearly discriminates between deletion and non-deletion kids, and over time, our children continue to make progress. We know we've heard the Bailey, we know we've seen the Vineland. How do they correlate? Sorry, I missed a step. There's some steps that we've done to improve the assessment of the Vineland. The previous strategies, we've given some recommendations around which version of the Vineland to use, as well as start points. We've encouraged that everybody complains all the domains of the Vineland, including the motor domain. In expressive communication, the manual states it, that you can give credit for any way of communicating. So we emphasize that and make sure that we give credit for any way of communicating. If your child's swatting for no, and every time he says no, he swats, that absolutely counts. And the ongoing efforts supported by ABOM to better improve the violence, similar to the steps I showed you for the Bailey. As I said before, I skipped it earlier, people are always interested in how do the Bailey and violence correlate. This data shows the Bailey and violence across 3 age groups using the receptive communication domain. As you can see, 0.5 to 0.7 is moderate correlation, and anywhere above 0.7 is high correlation. So for 2 of these ages, we actually have a high correlation, and for 1 of these ages, we have a moderate correlation. Usually for psychological measures, anything moderate and above is pretty good. So we see that the Bailey and Vineland are very highly correlated. Yes, we have shown that these measures can show statistically significant difference. But what about, are these changes clinically meaningful? And that's the question FDA wants to see, right? Is it statistically significant and clinically meaningful? And how do we assess that? We got a small grant from NIH to assess meaningful change. This is the definition we came up with. Meaningful change is the degree or level of change that you, as a caregiver, feels noticeably impacts your child's daily functioning or family quality of life that is important to the child or the family. How did we go about doing this? We brought together Delphi panels, which included parents of individuals with Angelman syndrome, divided them into 4 groups, deletion, non-deletion, under 5, over 5. We brought together clinicians who work with these individuals, as well as the research team. And for 6 months, we had meetings twice monthly to go through all the 10 domains of the Vineland and 5 domains of the Bailey. We had 10 sessions total, and this truly was a labor of love. And we really, really want to thank all the families who participated. This was twice a month, 5 to 7. They set aside everything that they had to do and participate in this Delphi panel to tell us what was meaningful to them. So what did we do? We broke down the different domains into scenarios. So for example, I'm going to show you the personal domain. We broke it down into 3 scenarios. We showed them a baseline of where the child is. We showed them the different items of the Vineland and said, for the personal domain, what's the smallest level that you would find clinically meaningful? And then they would give us their ratings. For example, here, 14 points is where they found that was the smallest minimum meaningful change they accepted. So we did this for 3 scenarios. So we had them do a rating for round 1, where they did it individually. They came together in a group and did a discussion, and they rated it. They did the discussions. They had a discussion and rated it individually. When we did these groups, we intentionally kept deletion and non-deletion separate because we didn't want them to impact each other. And then for the 3rd group, we brought them all together and had a consensus rating. As you can see in round 1, the consensus was 14. In round 2, it was 14. In round 3, it was 14. And only 1 clinician and 1 parent indicated a different rating. So this was just 1 scenario for the personal domain. For the personal domain, we divided into 3 scenarios. So we had scenario 1, scenario 2, scenario 3. These form the anchor for the personal domain. We also took the data from the natural history study and developed distribution-based approaches. So what we are providing are these minimum change thresholds using both the anchor-based approaches and distribution-based approaches for all the 10 domains of the Vineland and the 5 domains of the Bailey. And we're hoping that once we come to consensus, we're going to be providing this document to talk about what thresholds are clinically meaningful for both the Bailey and the Vineland. In summary, the Bailey and Vineland are appropriate and valid measures to use to assess development in a clinical trial. We truly believe that a combination of direct assessment and parent report provides a comprehensive assessment of your child at that point in time. The Bailey and Vineland target domains that are identified by clinicians as important. It is really critical to standardize the administration of the Bailey and the Vineland. This is important to ensure consistency across sites and examiners, to reduce variability in assessment, and to improve accuracy and sensitivity to capture change over time. This endeavor has taken a lot of work, and I firstly want to thank my partner in crime, Dr. Ann Wheeler, who's calling in virtually, and the whole team at RTI. I also want to acknowledge this is the list of all the clinicians in the natural history study who have administered the Bailey and Vineland. And finally, we want to thank you families to help us provide all this data, to help us forge ahead with clinical trials. Thank you.